Good afternoon. Thank you all for coming to the Understanding Common Psychiatric Disorders in Children and Adolescents. This is part two of the webinar. Yesterday was part one, where we talked about, and today we will be talking about depression and symptoms of psychosis. This is put on by both Kids Mental Health Pierce County and Mary Bridge Children's. And we have Dr. Mary Catherine Rensko, our pediatric psychiatrist here to present with us today. I'll let you go ahead and take over. Thank you.
Okay, so housekeeping items. Apparently, part one is already up. The other thing for the people who really want to know at the get-go, there are no CEUs or CMEs. So if that changes your availability, I understand. I am the psychiatrist who is within Mary Bridge. So I see kids when they're in the emergency department or when they are hospitalized for medical concerns, where there might also be a psychiatric overlay or a comorbidity that's affecting their treatment and care. So today we're going to talk about depression, and then we're going to talk about symptoms of psychosis. I will make all of these things available. So if you're someone who just wants to sit back and listen, please do that. You can ask questions, raise hands, unmute, or put it in the chat, and Jasmine's going to watch because I will not be able to see it right away. So we're going to first talk about depression. The number of slides may seem daunting if you can see them, but some of them are cases, so they'll go by pretty quickly. But we will talk about the background of depression, how to make the diagnosis, and different types of depression that you may be able to diagnose, and then treatment options that you will come to from clarifying what their diagnosis is. So major depressive disorder has the highest lifetime prevalence of any psychiatric disorder. Again, it tends to be women, which is a similar theme from yesterday. The mean age of onset is 40, and then half of the presentations occur basically in adulthood. It's more common in rural areas. There's no difference among races, but as we talked about yesterday with stigma and marginalized people, there tends to be underdiagnosis of mood disorders and overdiagnosis of schizophrenia in patients whose racial or cultural background differs from whoever's examining them. Again, so that speaks to one's own personal implicit bias and just recognizing, am I taking all of these things as objective data? Or am I looking at this person simply because of the culture they come from or the skin color that they have? And is that impacting my diagnosis at all? There is a prevalence about 2% in children of major depressive disorder, and then it continues to increase. So it goes up in adolescence, and again, 50% of the onset occurs in adulthood. They may or may not have a significant loss or precipitating event. There's lots of patients who will say, but nothing happened. I don't know why this is happening. And that may be the case. They don't have to have had any large change or significant stress to have the start of depression. There's a high level of comorbidity. So between 40 and 90% will have some other psychiatric disorder. And then there is a significant rate of recurrence, very high recurrence after 5 years. Again, this will impact the length of treatment or the suggestion of treatment that one may make. And then there was an increase in adolescent suicide rates after the black box warning was put in place for antidepressants. However, we continue to use antidepressants, and now that they're back being used, perhaps the same or even more than they were previous to the black box warning, the number of adolescent suicides continues to rise. So some of the theories about why depression occurs, it does run in families. There's a high amount of family loading. That is actually the most predictive factor of someone developing major depressive disorder. There are genetic vulnerabilities. There's also temperament. There may be people who are more prone to it because they have less coping skills, a more negative outlook. Exposure to violence leads to higher risks, socioeconomic status, low IQ, and then all of these things will put people at risk. So there's also a thought that there's transactional stress. So if someone is, let's say, in a lower socioeconomic bracket, they have more food insecurity, they are perhaps living in an area that has more violence, they then are exposed to more violence, which perpetuates their risk and then may lead to a more negative coping strategy, a more pessimistic outlook because they believe, their physical and environmental stresses are not going to change. So there is some back and forth. And then there's also early cannabis use that's associated with increased risk for depression and suicidality. And yesterday we talked about early cannabis use also being associated with an increased risk of acquiring an anxiety disorder. So these are usually things that I will put in when I'm talking to teens about cannabis use, especially in a state where it's legalized for adults, as to reasons that it might not benefit them in the long run when we're talking about pros and cons of using marijuana. Some of the prevention that could occur and the course of the disorder itself. We can work to treat parents to decrease social stressors and then to treat other disorders that might be comorbid and might be fueling their depression. So for example, if someone has social anxiety disorder and then in turn they're not having any social interactions, they are then not doing any preferred activities, they may start to get depression because they're having lack of interest all of a sudden, they're not involving themselves in anything, they have less energy, they may get depressed in part because of the social anxiety disorder. So we can treat that comorbidity and perhaps affect the depression itself. There tends to be indicated interventions for depression. Universal interventions don't have as great of an effect. So what you can think of is think about a school. Talking to the entire school about depression would not have as great of an effect as perhaps screening for depression and then targeting your interventions to the population that screened positive for potential depression. So this is an importance of doing screenings, especially in primary care offices. And sometimes schools will do universal screeners to pick up kids that would be helpful to put into groups that they might be running. It might be kids that guidance counselors want to check in with because that'll have a greater effect. Lifestyle modification, pursuit of enjoyable and meaningful activities, and then avoidance of situations that they know will be unproductive or stressful, if at all able to avoid those situations. Sometimes there's family events that are unavoidable or people in their lives that obviously they cannot be away from, but kind of balancing the scale with more enjoyable or meaningful activities is always helpful. There's also a app called the Positive Activity Jackpot. And I don't recall if I put it in the resources, but if not, I'll put it in the chat. It is an app that's kind of like roulette, where somebody can put in things that they're interested in and then spin a little wheel and it'll give them ideas of an activity to do. It could say whether they should do it with a friend. It used to be able to sync with phone contacts and calendar so that you could actually send an invite to your friend to go bowling, for example, and then it would set a reminder as well in helping increase positive activities. 20 to 40% of depressed youth develop bipolar disorder. There is a high risk for developing bipolar. If someone has more psychotic depression, a family history of depression, and if they have ever taken a medication which led to mania or hypomania, then that's all a higher risk for developing bipolar disorder. And with any adolescent, if you are screening them for depression and considering treatment with a medication, you should also be asking them about symptoms of bipolar and family history to know if that's something that you should emphasize when you're giving risks and benefits when talking about medications. So a case is an 11-year-old African-American female. She came to the ER with her grandmother. She had expressed suicidal ideation at school. She had moved from Arizona and was expecting to go back there after the school year. She'd had consistently low mood, no longer interested in hanging out with her friends, whereas she used to be asking grandma to go out a lot. It's now hard for her to get out of bed, and grandma says it's really hard to get to school in the morning. She's having increasing suicidal thoughts, and she went so far as poking a hole through her hand. And she also said she could potentially use a knife to kill herself. And she thought that either of these things could be lethal. And this has been occurring consistently for months. She can't even concentrate if she's doing kind of mundane activities. And then her sleep has been both excessive with some difficulty initiating sleep. And then grandma mentioned that it's been difficult to get her to eat and that she always is forgetting that it's a mealtime. So she had recently started sertraline, otherwise known as Zoloft, and she saw a therapist once, but there continued to be therapist cancellations for their own sickness or days off. And then grandma was canceling appointments, so there's been a lapse in therapy. This case would meet criteria for major depressive disorder. So this is an example, and I put the significant symptoms that I would be looking for to meet the diagnostic criteria for major depressive disorder. So there may be some differences that you would want to look for. So with depression, if it's considered a major depressive episode, there has been at least 2 weeks where someone is consistently having a low mood or anhedonia, which is lack of pleasure and enjoyment. And then they also additionally have to have at least 5 symptoms from the diagnostic criteria. And it needs to be functionally impairing to either them or their family. So the differences that you might look for between adults and children, children, when you look at them by themselves and compare them to adolescents, they tend to be more irritable, maybe have more tantrums, maybe complain more about headaches, belly aches, tiredness. They may even have hallucinations. And then the thing that parents might notice is they don't want to play with their friends, or maybe they don't want to go to practices for activities. Rather than them saying the word, I feel depressed or I feel sad, they might not have appropriate words to really describe it yet. And then if you compared adolescents to children, they can be more melancholy, they could have more suicide attempts. They may be able to have the words to say, I don't feel the same, or things look really bleak. The other thing to just keep in mind, especially if you're treating people in the outpatient setting or in schools, especially here in Washington, is seasonal affective disorder lines up with darkness and with time of year and gets better. However, that also tends to coincide pretty closely with the school calendar. So you may need to track back and see, last week is when we started into the really dark days. Look back and see, did their depression coincide with more August, September-y, when they started to school and realized that they weren't feeling well or that they didn't want to hang out with friends, they didn't want to involve themselves in extracurriculars? Or did it truly happen with daylight savings time and being dark outside later in the day? So just something to keep in mind, especially here when it's significantly dark. Another case, 14-year-old female, she came into the hospital after increasing suicidal thoughts. She had had months of depressed mood, difficult sleeping, didn't have much of an appetite, had a lot of feelings of guilt that she was the reason why she was feeling so poorly. She was the reason her friends didn't want to spend time with her. She had no more interest in things she used to like, which was video games and watching TikTok makeup tutorials. She was having daily suicidal thoughts. She was not having any hallucinations. This is in contrast to the case of a 13-year-old male. So if you look at 14-year-old female, this had been going on majority. She'd had months of depressed mood. It had been happening nearly all the days, as opposed to this 13-year-old male who moved to Washington a few months ago, started into high school. He described it as silent bullying, so excluding him, not saying mean things, not being physically aggressive, but just not including him in things. And he thought that was because they were looking at him as a different race. So he started to eat lunch in the bathroom, or he would go to the office. He was texting his mom often when he was there, and he finally texted her something to the means of, I'm fed up, which she took to mean that he was suicidal. And he actually left the school, walked into the street, hoping to be hit by a car. So for this, he had endorsed periods of low mood, suicidal thoughts, but they were really tied to school. It didn't happen at all at home. His caregiver described that when he was at home, he was doing the things that he always liked to do. He would want to go out. He would want to play video games. He would want to play on his phone. He was still communicating with friends from the old school in a different state. So in this instance, this would be more appropriate to call it adjustment disorder. It was really these symptoms beginning because of a change. So for him, the stress was starting into high school as well as a new state to start into school. So the collateral from his mom was really helpful to make a distinguishment between the two diagnoses because they're treated differently. So again, major depressive disorder, there has to be a 2-week period where they are either depressed or anhedonic, aka not getting interest or pleasure out of things. They have to have at least one of those. They could have both, but that is one of the major criteria. And then there needs to be 5 or more symptoms of the other things, basically. So sleep changes, loss of interest, guilt, changes in energy, changes in concentration. The concentration is really important to ask, is this different than normal? So all of these, whenever I ask them, I say, hey, have you ever had a period where for at least a couple weeks you're consistently down, maybe even feeling depressed? And they might say, yes. Okay, during that time, did you notice any change in your sleep? Oh yeah, I can't get to sleep. I've tried a million things. Okay, during that time, how were your interests? I didn't want to do anything. I used to love soccer, I used to love running, and I didn't want to do any of it. So you always ask about that time period. And you never want to, I guess the best way to describe it is double count symptoms. So if you're asking kind of for a full evaluation, you want to specify, when you have these sleep problems, do you think it's because of your mood being low? And they may say yes or no. For somebody else, they might say, yeah, my sleep's been really bad, but I've been on a dose of steroids, and so it's just really hard to sleep while I'm taking that. Or I just got a new phone, and my parents don't know that I made an Instagram account, and so I'm chatting all night with my friends, but if I wanted to sleep, I could. So it's really important to specify, do we think these things are happening because of your low mood? Or for concentration, do you have baseline concentration difficulties? Oh, yeah, by the way, I have ADHD. Or I have a lot of anxiety in school. I'm really worried about my performance. My teachers keep saying that I'm distracted because I keep thinking, am I going to get the question right when they ask it? How are my grades going? So you can ask some clarifying questions to see if these symptoms really fit with low mood. You can better describe your diagnosis by saying the severity of it. So is it mild, moderate, or severe? There's no numerical cutoff per se. Some people use the PHQ-9 screener to give them this. Basically, mild is you just have enough to meet a disorder of major depressive disorder, like enough symptoms that it just squeaks by. Severe is every single symptom, and then moderate is in between. So think of it that way with extremes. Mild, barely meeting the criteria. Severe, like there's no chance they wouldn't get this diagnosis, and then moderate is in between. Sometimes there could be psychotic features, and you really want to focus on timeline of when they might be having hallucinations to determine if it lines up with them being depressed and only when they're depressed, or if it could be from another reason. And then you can say whether they're in partial remission or full remission, depending on how their symptoms are at the time. So in partial remission, some of the symptoms have gotten better, but not all of them. In full remission, they're no longer meeting criteria. And then unspecified, if you know there's some other way to describe it, you just didn't have enough time or they didn't describe it in enough detail for you to really give it one of those specifiers. There are some other ones I can say I rarely use them. I guess psychotic features I'll use and catatonia sometimes, but otherwise, I typically don't put them. An additional case, so a 17-year-old African-American male, he was brought into our emergency department while he was detained for aggression. He often refuses to speak. He has vague religious preferences that really only seem to come up when he wants to gain access to something. So, for example, saying, oh, my religion says I should walk, so I don't need to be in this ER bay because I need to be walking in the hallway. But nothing that was really making a ton of sense. And then paranoia over having a safety sitter, so someone who observes him while he's there to make sure that he stays safe within the room and within our facility. When I spoke to parents, they gave me some collateral that it had just been a few hours where he was at home after being released from juvenile detention. He immediately wanted access back to some of his preferred items, and his family said no. So he then started shouting, destroying things. They also described him as constantly irritable. He has huge blowups. It happens at least every other day. It might be for something very small, like running out of peanut butter, and he then destroys the kitchen. He's been suspended from school. They said that his irritability is consistently in school as well, and they did not see any evidence of a prior manic episode. So that is an example of disruptive mood dysregulation disorder. Someone may have severe temper outbursts, either verbally or behaviorally, that seem way out of proportion or much, 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 much longer than whatever provoked them. A big thing for this, it needs to be inconsistent with their developmental level. So if this was, for example, a 3-year-old who was told, no, you cannot have a cookie before dinner, and they threw their body down and were kicking, and in that case ended up breaking some things because they were thrashing their body around, that's much different. We would expect that as a tantrum at that age. These need to occur 3 or more times weekly, so very frequently. If this is an instance where someone comes in and describes disruptive behavior, but they say, oh, it's maybe every month or so, it's probably not disruptive mood dysregulation disorder. The other thing is their mood needs to be persistently irritable most of the day, and others need to notice that. It needs to be present for a long time, for 12 months, and then it needs to be present in multiple settings. So this cannot coexist with oppositional defiant disorder, where someone would have irritability at baseline, but they wouldn't have as big of blowups that would seem as out of context or developmentally inappropriate. This would also be different than intermittent explosive disorder, where someone would have, again, huge outbursts, but they would be at the drop of a hat. They would not be irritable in between, and they then would feel remorseful or guilty because of it. So you can tease it out a little bit with what is their mood in between these outbursts? How often do the outbursts happen? Can other people notice them? And has it been persistent? You can kind of start to narrow down, okay, this might be disruptive mood dysregulation. And they cannot have had more than one day of manic or hypomanic symptoms. So again, this is just helping you to narrow it down where you're not concerned that it's bipolar disorder, which would be very episodic. They wouldn't be consistently irritable. They would have these big spurts of behavior that's not like themselves with other associated things for bipolar disorder. There's also substance-induced for depression due to another medical condition. These ones you probably won't see. In the hospital, they see them, but that's kind of a cherry-picked population, that those people are medically ill, and so they might have this crop up. It's a very small lifetime prevalence. It is prominent. There's a persistent disturbance, and you would have some other abnormalities. So if it were due to substances, if they had a period of sobriety or not using the medication, they may feel fine. Their mood may be well until they use this medication. And there are a few prescribed medications that can do it: interferon, corticosteroids, digoxin, and then some anti-epileptic drugs. It will usually resolve within about a month of stopping either drug use or medication use. And if it were due to another medical problem, they would have to have that medical problem going on while they had the depression. So it couldn't just precede it as a stress. It would need to be directly caused by the medical condition. So in general, you want to have a baseline, and you want to make sure that if you're diagnosing depression, it's truly depression. So there will be a cohesive interview. You may have done some screening. So a screening tool that you used, maybe they were at their primary care office and they were given the PHQ-9. Maybe they came in to an emergency department and they were given the Columbia Suicide Severity Scale, that would point them in the direction of, oh, hey, depression or suicidal thoughts might be of concern, so I should broaden my interview. You may want to do a physical exam that's very targeted. So this often doesn't happen unless they're seeing their primary care or a psychiatrist or an ER doctor. There may be some labs to rule out. However, there's no clinically validated imaging tests or lab tests that are required for the diagnosis. They're just some helpful things. Sometimes if you have a suspicion of something else going on, if something runs in the family, if they're describing other symptoms that would make you do these labs. So pregnancy, certain people may be wanting to talk more about taking SSRIs while pregnant. So they would want to know if they were pregnant or not before deliberating whether to take the medication. Ruling out anemia or baseline bleeding problems could be helpful. If they have a history of anemia, it runs in the family, they have heavy menses, that may be helpful. It's unlikely, but it could be the pure cause of fatigue and then low mood if they're really affected by lack of sleep. Knowing if they have baseline bleeding problems could be helpful. Again, SSRIs can affect platelet quality, so it does not affect the quantity, aka the number of platelets that show up on lab tests, but it can just affect how well those platelets work to do their job of helping frontline bleeding stop. A Chem7 or the equivalent, it could show you if they are at baseline low in sodium, because again, some SSRIs can affect sodium, usually not as much in children who are resilient, more so in older people who have a lot more health problems. And then you could do liver tests if you were going to start duloxetine, or if they had any recurrent substance use that you were just worried about, ALT to begin with. Sometimes it's useful to check thyroid studies. Again, you usually have other things that you're worried about, like heat or cold intolerance, hair, skin, nail changes, fatigue. Vitamin D is often checked just out here because of the lack of sunlight. B12, folate, again, only if you suspect it. If they're having kind of on sensations in legs, any gait abnormalities, then you could check those things. But none of these are required. They're just things that you might do to reassure the patient or because there's other physical findings going on. If you're not sure, if your suspicions are raised that someone could have depression, then you can use a screener to support your diagnosis. There should never, ever be a time that someone is given a PHQ-9 and said, okay, you scored high enough, now you have depression. It's just to screen for things. It's not to diagnose anything. It can also be helpful to track responses to treatment. It can show some level of objectivity. So in other health systems, they sometimes repeatedly give people PHQ-9s or GAD-7s or CSSRSs at certain time intervals to show them the progress of their treatment. And then it can graph it out. And it's a nice little thing for patients to look at or to go over if they're having stalls in their treatment, or if they're just doubting, how do I know that this is working? Oh, well, I can show you this data that shows your levels of depression based on the PHQ-9 have gone down. So there's PHQ-2, and then it expands to the PHQ-9. The PHQ-2 is just the first two questions. So self-report, is there little interest in pleasure or doing things? And do they feel down, depressed, or hopeless? And then it expands to the PHQ-9. It again is just a self-report. And then the scores range from mild to moderate, moderate to severe, and then severe. So again, it gives some backup. If you're trying to specify the type of depression and trying to rate the severity, this can be helpful. It also just gives specific questions asked in the same way. If you're struggling to ask those questions to the patient and figure out a meaningful way to ask the questions, if you just can't reword it in a way that they're understanding, you can sometimes go through these with them and ask any other questions about, well, when is this depressed mood happening? What environments does it happen in? How long has it been lasting? Do other people notice it? And if you're giving out a PHQ-9, you always have to look at the last question because that's about suicide. So there should never be a time when you give someone a PHQ-9 and review it after they've left. You should always review it while they're still there, because if they answered yes to the question about suicide, you need to be talking to them and potentially restricting lethal means or coming up with a safety plan. It is not good to let them go and then look back and say, oh no, they answered yes to the question about suicide. And then sometimes the CSSRS is given. It's a screen of suicidal thoughts. There's a lifetime and a recent version. There are many, many, many versions for specific populations that exist. If you go onto the website that houses all of the different CSSRSs, there's even ones for developmentally disabled. There's ones for younger kids. They are not necessarily as validated in terms of age, but they could still be helpful in re-asking the questions in a developmentally appropriate way. So whereas the regular CSSRS might say, are you having any suicidal thoughts? The younger version might say, have you ever had thoughts about making yourself die on purpose? Where a younger kid may understand those words a lot more than they would about suicidal thoughts. If you're in doubt, simplify in your mind. So all psychiatric diagnoses cause functional impairment. It interferes with something, either the own child's life, the family's life, their ability to go about their regular activities. If it doesn't bother the family, it is not our business. They may not find it to be a problem at all. They might be introverted. They might say, you know, there was a big stress, but we feel as if it's not impacting them because they're still doing their activities. They're still taking care of themselves. So it's not necessarily our business to say that it's a problem unless the family is saying that there's impairment. And then I will often ask people what symptoms are causing you the most suffering. So they can sometimes hone in on like the lack of sleep or the low energy. Because if they're coming in with kind of a potpourri of symptoms and you don't know where to go, you can at least start with what's bothering them the most. And then also that can sometimes target what medications I'm going to talk about more because they feel perhaps that lack of energy is the biggest issue. Then maybe we talk about FDA approved medicines, but then we talk about something off label and I let them come to the decision of what to use. And family preference overrules everything. So I tend to tell people, hey, I'm going to talk to you about medications because your diagnosis has told me that medication will be helpful based on the severity of your depression. That's what the research shows. Do you want me to talk about all the options? Do you want me to tell you what the approved options are? Do you want me to tell you a suggestion? Do you want me to give you information? How would you like to talk about it and come to the decision? And they'll usually tell me, they'll say, you know what, you're the doctor and like, I just want your opinion. You tell me. Or I really like to have information. I want to talk about everything and come to my decision after a couple days. Or there's sometimes occasions where I'll meet somebody in the emergency room, and that's the only time I'm ever meeting them. And they say, I would love to talk about it and then take it to my family doctor and talk about it more so that I can come to a decision with them. So any way around it, it works so long as you're kind of planting the seed of, hey, this is what's recommended. And then you can come to a decision based upon what information I give you. So the treatment is always based upon diagnosis. When people are asking for safety questions, you should never ever ask a compound question or a leading question. This is like a big pet peeve of mine when I even go to my own doctor's office. If you phrased something as, you've never had suicidal thoughts, right? You're going to get a much different answer than if you say, are you having any thoughts of suicide? Are you having any thoughts that you want to make yourself die? Are you having any thoughts that you don't want to be alive anymore? You get a much different answer and usually an honest answer. There is no research that says asking about suicide increases suicide. It is a safe question to ask. You just have to know what to do next. So if safety is in question, you should be talking about safety planning, how to restrict lethal means, deliberating either in your mind or with the patient as to, are they safe enough to leave this place? Or do they need some higher level of care, either to continue evaluating them, or do they need a higher level of care because they can't keep themselves safe? And we certainly can't keep them safe wherever they are right now. If it's in school, if it's at an after-school activity, if it's at the primary care office. Some of them have embedded mental health techs. There's sometimes the counselors, the safety resource officers within the school, people that can come from crisis teams and respond in the moment. But you should be asking directly about safety I always inform parents how to ask it, and we usually practice it in the session too. So if you've diagnosed them with depression, you want to try to specify if it's mild, moderate, or severe. And you've come to that because you've asked them all of their symptoms, and you can say, okay, they're mild, they're hardly meeting the criteria for major depression. In that case, you can provide them with education, they can work on behavioral activation, they could go and do cognitive behavioral therapy and come back in like a month and a half. And that usually is sufficient. If it gets to be moderate or severe, those are considerations for medication. So if it's moderate and they have significant impairment, then you can have a conversation. Hey, we could do cognitive behavioral therapy, we could do medication, we could do both, but you have the options. So mild, there's not much to do other than therapy and coming back. Moderate, there's discussions and options because research has shown it's kind of a flip of the coin as to which gives the best benefit. And when it gets to severe, you're recommending both. So oftentimes I will phrase it to families as, hey, we talked about the symptoms that led me to calling it by this name, and I'm calling it major depressive disorder. Here's why I'm doing that. And I go through all the symptoms they described to me, and I say, with the way you've described it, you're meeting all of the criteria, so we would call it severe. And in that case, the research has shown that therapy plus medication is going to give you the best benefit and reduction of symptoms. And then you take it from there and see if they're interested in doing both of those things. Sometimes they're only willing to do one is better than none. And you can always inform them that this is not the only day you'll ever get to make this decision. This is the first time maybe somebody's presenting it to you, but you can change your mind. If you say, no, I don't want medication right now, that's fine. However, you can always ask again. We can reconsider after a while. You can try therapy for a while. Whatever the case may be, they just need to know that there's still an open door. So these are the medications that are FDA approved for major depressive disorder. They have approvals for other things at certain ages, but each of these are approved for major depressive disorder. There's less data when it comes to OCD for certain ones, but for these four, they're approved for major depression. They have good evidence. They have generic versions, and they're approved within the age range. Every young person gets a black box warning if they're using a medication that could be used for depression. So it doesn't necessarily just have to be an SSRI. Think of it as any antidepressant medicine. I will even give people the warning if I'm treating anxiety, but it's a medication that I could also use for depression, then I'll give them the warning for it as well. Anybody who's 24 years and younger. So there have been black box warnings for many years now that say there could be increased suicidality. And what that means is they could have worsening suicidal thoughts. They could have unusual changes in behavior. It can happen during the first few months, or if the dose changes, whether it increases or decreases. But most of the studies that have looked at this say that there's less risk than what they initially thought. And it's vague as to when or if the risk ever goes away. And certainly it would seem odd to me if magically when you turned 25, your body would have morphed that this warning doesn't exist anymore. So it's something that I let all younger people know about. If you're treating populations, for example, military, a lot of those people who are in the military still get this warning because they may have enlisted at 17 or 18. Again, antidepressants can be SSRIs. They can also be SNRIs, so like Wellbutrin. They could be tricyclic antidepressants like amitriptyline. It could be mirtazapine called Remeron or bupropion. It could be Effexor, Cymbalta. So anything that you could use to treat depression, you want to give a young person the risk, the black box warning, and tell their parent about it. And I always stress to people, this is the reason why we check in with younger people more often than we might with an adult, because this risk exists, this warning exists. However, I treat depression, and a large symptom of depression can be suicidal thoughts. And I know by treating depression that can go down. So this risk is not big enough for me to avoid treating depression. One meta-analysis showed a 1% risk difference between drug and placebo with respect to suicidal events and no deaths by suicide. I usually emphasize to people that none of the research has shown deaths by suicide. It has just shown increase in suicidal thoughts or suicidal behaviors. Um, and I always give people a lot of expectations about the medication. So if you were to start somebody on an antidepressant and just said, okay, this is for depression and it should make your depression better, I will see you in a month, then there's a whole lot of people who would stop taking it because you haven't warned them about a lot of things that might happen. So you don't want to let them be surprised. Giving them an expectation for how long the medication could take to show significant impact. So at least 4 weeks of consistently taking it. I will always tell people that doesn't mean you're not going to notice things. It just means we haven't reached the full effect. So I want you to keep taking it. And I often describe seeing the effects in yourself like if you started to do diet and exercise. If you look at your own body every day, you might not notice changes in how you look, but other people who haven't seen you in a while might say, oh my goodness, look how different you are. Same with depression. If you're living in your mind and your body every day, you might not notice that a lot of things have changed. But if you ask family, friends, teammates, they might say, you know what, they're coming out of their room a lot more. They want to do family activities. They're going to practice. They're laughing more. They're not as tearful. They just seem to enjoy things more. You might get a lot more answers. So I often tell people you probably want to check in with close people in your life because they may notice things better than you do. And then I always phrase things as some anticipated annoyances. So you might expect some annoyances in the first week or so. Those could be things like trouble sleeping. For certain people, it makes you sleep more or it keeps you up at night. You might have belly upset. That could look like kind of a sour stomach or nausea. It could look like diarrhea or constipation. You might have a little headache. You could have this thing happen that they call activation, where it just feels like you're a little bit more hyped. And people who don't know that may feel that that's more anxious. So if you give them these expectations and tell them, hey, these things might happen, that is some knowledge that it's starting to go into your body and they should go away. And you can treat them if they're bothering you. So if you're having diarrhea, you can take Imodium. If you're having a headache, you can take Tylenol. If you have this phenomenon where you feel a little bit more hyped, remind yourself, oh, it might be the medication taking effect and it should go away. A lot more people will consistently take it if they expect that these things are going to go away and they talk to you about them and they know that there's things that they could do to get through it. And then in Washington, which is a lot different than other states, 13 and older can make the medication decisions without their parental agreement or consent. So they could go to an appointment all by themselves. They could go in and say, I definitely want medication. And then their parent could walk right in and say, absolutely not, we're not doing medication. And you can still allow them to have it. You can still write the prescription. I tell kids this. I also tell them that realistically, if their parent is paying for their insurance, they may be able to see it. They may look for it. They might not be willing to pay for it or pick it up. And so those are conversations that sometimes I have with kids about, do you want to do it? How can we make it available for you? What are going to be the barriers if that's the case and their parent doesn't agree? And how would we keep you safe with this medication if your parents aren't completely on board? But I ultimately want your parents to keep control of the medicine. So how do we bridge that gap? Some of the adverse effects that could happen, some of the common ones and some of the scary ones, and that's usually how I phrase it to patients is, hey, you might notice some of these annoyances in the first few weeks. There's some that are more common, but I also want to let you know about the really scary ones that you would watch out for so that you would know what to do if these did happen, although it's rare. So one of the ones, let's see, serotonin syndrome I'll talk about. What to notice, that they may feel shaky, they might feel flu-like all of a sudden and nobody else is sick, it's not flu season. They know that it coincided with taking the medication. Mania, hyponatremia, rare, but if they have a baseline problem where sodium is an issue, then that might be something to keep an eye on. And again, there's an increased risk of bleeding. If they have a known clotting disorder, it might be something to talk between hematology and the prescriber about. And then angle closure glaucoma. As it gets to like adolescence, pre-adolescence, I will talk about the possibility of anorgasmia and delayed ejaculation. And I will often phrase it as you may or may not be sexually active. We've probably already talked about that in our appointment, but if not, whether you're sexually active or whether it's masturbation, you might notice that it's a little different. It doesn't happen to everybody, but it's a potential. So just keep an eye out for it. And if you feel like it's an ongoing issue, then talk to me about it because there's things we could do to offset it. But I don't want someone to just immediately assume, especially at like the height of puberty, when they're very focused on potentially sex and masturbation. I don't want them to think, oh my gosh, this is definitely going to happen. I'm never taking that medicine because that might not be the case. In regards to therapy, there's only 2 evidence-based therapies for major depressive disorder in young people. Cognitive behavioral therapy, which is focused a lot on homework, agenda setting, monitoring someone's mood, and having things to do outside of the appointment. Interpersonal therapy, which is manualized type of therapy. It helps them on communication patterns, types of responses, and it works on changing communication patterns to then affect how the relationships are going, which improves mood. They're both challenging if parents are not buying in because vast majority of kids need their parents to get them to the appointment, to pay a copay for the appointment, and to allow them and agree with them that things need to change. The goals for major depression are remission. So response is considered about a 50% reduction in symptoms that last at least 2 weeks, as opposed to remission, which is a period of 2 weeks, but less than 2 months where you have hardly any symptoms. Recovery is a more substantial period of time where you have absence of most of the symptoms. And then you can phrase something as either a relapse or a recurrence based upon when the depressive symptoms came back. So a recurrence is you think you're through it. It's been about 2 months or so, and there's a new episode, as opposed to a relapse where you're in a pretty short period of time, only a few weeks, and the symptoms come back. Trials of medications should be at least 4 to 6 weeks before switching. You should also consider increasing the dose. If you've gone the 4 to 6 weeks, when you've increased dose, you're still not getting any benefit, you can consider switching to a second SSRI, aka a different one. You always want to try one medication at a time. You don't want to duplicate or double up on things. And then if trials are ineffective, you also need to look at, are they compliant? I will do similar to substance use, a kind of gentle assumption of, okay, out of the last month, how many days do you think you've missed? Or what percentage of the time have you taken your medication? So assuming that they're going to miss some days and giving them the allowance to have a couple miss-ups, it's going to result in them being a lot more honest. And then did they stop too early? There's a lot of kids who say, you know what, I took it for like 3 or 4 weeks and I was feeling a lot better, so I stopped it. Well, you actually did not take it long enough, and we weren't even out of a remission phase, so they probably just had incomplete trial. This is just a physical representation of that same thing. So the response is when you have 50% of symptoms, and then remission occurs early on as opposed to recovery, which is a few months out. And then you could have relapses throughout the early parts when you're starting to feel better and then have symptoms recur or come back, as opposed to a recurrence, which is an additional episode that happens quite a while out. So how long do you treat them? Once you find a helpful dose where someone has met remission, so all or nearly all of their symptoms are gone, you want to keep them at that helpful dose for at least 6 to 12 months if it's a single episode or the first time they've ever had a depressive episode. If they have recurrent episodes, so if they've had depression more than once, then you want to just continue on the medication. There's nothing currently research-wise that says there's any downsides to continuing on medication. And the vast majority of people who have had depression and then felt relief don't want to have depression again. So this is just a conversation to have up front. When you're discussing medications, you should talk about, why am I using this? What are the options? What are the alternatives? What is the prognosis? How long do I expect to be on it? And then how, if ever, would I get off it? And then how to stop it. You will typically go down incrementally. If they start to have crummy feelings, then you're going to either stop going down for a little while or go slower. Prozac, aka fluoxetine, tends to be self-tapering. It has a very long half-life. And ideally, you'd want to be off one medication before starting another. But if they feel like, my symptoms are so overwhelming, I can't possibly wait to completely get rid of one medication, then you might have to cross them over themselves. So the phenomenon of discontinuation, you can have changes in mood. So if you stop a medication and you have this syndrome occur, you can have irritability, agitation, dizziness. Some people will talk about having these kind of electrical shock sensations, problem sleeping, ringing in your ears, tiredness. They tend to feel really crummy, and they will notice that this has happened when they've either decreased suddenly or stopped suddenly and missed a dose, like if they went on vacation and missed multiple doses for a while. So these are the references for that portion of the talk. Does anybody have questions before I move on to symptoms of psychosis?
There was a question in the chat about the app you mentioned, the Positive
Oh, yeah.
Activity Jackpot. Someone was just asking if you had additional information on it. I was able to pull up one from the DoD, just not sure if that
Yep.
was the correct one. Okay.
That is the correct one. So it was developed by the VA and the DoD. It's available for free to everybody. That's just the people who developed it and had money to fund the research. So you can look at that if you're looking at doing behavioral activation. It's particularly helpful. And for the kind of kids who are just kind of Eeyore-ish and they're like, well, I don't know what to do. I never have anything. I can't think of anything that I'd even want to do. This might be something to kind of jumpstart them into getting back to activities.
I posted the fact sheet from the DoD website
Yeah.
in the chat.
So we will also, let's see, I listed it in here. These are also helpful resources that, again, when all the slides are available, these are clickable links. So there is the PALS websites, which is, oh, I can't remember what it stands for, but it's basically the psychiatry liaison site through Seattle Children's. They have an anxiety care guide. They have a depression care guide. They also have medication care guides. American Academy of Child and Adolescent Psychiatry has a website with many resources that you don't need to be a member to get. So they have parent medication guides, they have psychoeducation handouts, they have, I think, a primary care toolkit, and it has discussions about diagnosis, it has recommendations for medications. It also just has a lot of like pop culture-y information, like when 13 Reasons Why was the big sensation, they had a whole little toolkit of how to talk to your kids about that. And then Kids Mental Health Pierce County also has lots of local information as well as some national information. So those are things that people can look for so that they can either have them available for their own kids, for kids that they're treating, for kids they interact with, maybe they're coaching or mentoring. Okay, so psychosis. We're going to talk about schizophrenia, bipolar affective disorder, and then other causes of psychosis. Here is a case that I saw, a 3-year-old African-American female who was typically developing, had a family history of bipolar disorder, and she had sudden onset of visual and tactile hallucinations of bugs crawling on her. Mom had given melatonin to help her sleep. She woke a couple hours later and then was agitated, inconsolable, talking about having bugs in the room. And then when I was meeting with mom, she mentioned that last week a bee flew close to the kid's face and mom kind of freaked out and tried to get it away from her and was swatting a lot. And they're living in a domestic violence shelter. Their bio father was physically abusive, so mom and child fled many states away. So in going in and talking with the kiddo, the child, again, this is a younger child, preschool age. So there was elements of playing to observe during the encounter. It was important to have mom both there, but also ask mom to step out to see how the kids separated from mom and then how she reunited with mom. It was a normal mental status evaluation, but the staff who were there, so nursing staff, sitters, said that they may see her become agitated and fearful, but mom continually reassures her, pretends to brush away these bugs that aren't really there. And then it was assumed that as long as she was observed, the melatonin would have worked its way out of her system. So the assumption in this case is she was living in an unfamiliar environment. They had been in a very traumatic situation. They suddenly fled to an area that was completely unfamiliar, and something scary did happen, not only with the violence, but then to have a bee fly into her face and have her primary caregiver get really upset and swatting away was probably indicative of a little one's trauma reaction. And then also having some behavioral reinforcement of mom being very consoling, helping, paying attention when these bugs were supposedly crawling on her. So in this case, she got a little bit of medication to help her sleep, or if she was becoming overly agitated. And then mom got resources for outpatient family support and domestic violence resources, and was sent home after a couple of days of observation. So oftentimes people will see that a chief complaint says so-and-so's hallucinating, and they kind of, like as a treating provider or counselor or parent, they start to get very concerned. Most children who report psychotic-like symptoms do not have a psychotic illness, the vast majority. So the things that you need to take into account are what's the developmental context? How old are they? Are they misinterpreting things? Are they very imaginative? What is their cognitive and affective functioning? So are they cognitively delayed? Are they overly reactive to things? Are they overly anxious by their parents' accounts? And then having direct observations to look at patterns. Talking to the family members about historical patterns of, has this ever happened before? Have you noticed it, or has the child only said it to you in words? And then having direct observations from people outside the family to see, are you also seeing this when you're observing the child? So some common things that kids can voice. I'm hearing things, I'm seeing things. The guardians sometimes say they must be manic or they must be bipolar. And they're having mood swings, they're having huge ups and downs. And you obviously take into consideration whatever their parental concerns are, but you have to put it into whatever the appropriate context is. So here's a case of a 17-year-old African-American male. He's had multiple hospitalizations to psychiatric facilities, past diagnosis of major depressive disorder, ADHD, autism spectrum disorder. He has developmental delays, and then just kind of a catch-all diagnosis of psychosis. He's having auditory hallucinations that continue at night. He is not speaking much. It seems when he's in the middle of a sentence that he'll suddenly stop and look kind of confused, and he may or may not get back to the rest of whatever sentence or thought he was doing. He's paranoid. It's really difficult to get any emotion from him by just looking at him. It's very flat. He's tangential when he does speak, so he's talking about a ton of different concepts. None of them are connecting. And he's saying that he's having a hard time seeing what's real and what's not. He doesn't have any friends. He's been without housing, and this has been occurring multiple years with this persistent auditory hallucination. So that was an example of the start of what ended up as a schizophrenia diagnosis. Schizophrenia historically is a term that was created by Eugene Bleuler. He describes it as a schism, so a disconnect among thought, emotion, and behavior. There, in his description, were primary symptoms, which were the 4 A's. And those were associational disturbances of thought. So loose thoughts where they don't really connect to one another and it doesn't make sense how they associate those thoughts between one another. Affective, so mood disturbances. Autism, meaning lost in an internal world and reduced communication. This is just a term. It's not the diagnosis of autism spectrum disorder. It's just the way to describe something of being internally fixated. And then ambivalence. So having opposing thoughts and emotions happening simultaneously. So perhaps being paranoid, and still managing to be very happy at once, or overly sad, but not really understanding why they're sad. And then the secondary symptoms of hallucinations or delusions. So with epidemiology, the patients tend to be more withdrawn and not wanting to engage as much. That is something that I was always trained for. It's anecdotally been pretty true. That usually happens before the age of 25 and it persists throughout lifetime. So it tends to peak earlier in males, more of high school to young adulthood, and older in females, more kind of late, early college to mid adulthood. If you look at the total numbers of who has schizophrenia, it's pretty equal between males and females. It's just an earlier onset with men. And it's very rare before the age of 13. If it's ever somebody before the age of 13, you should really, really be second guessing yourself if this is high up on your list of diagnoses. The lifetime prevalence is pretty low. It's 1% of the US population. It may feel that you see this a lot, but you also have to look at what environment am I in. If, for example, at Mary Bridge, it's a community hospital. We're in a moderate sized city. There's a lot of socioeconomic differences in different parts of the city. There's a large city near us. So it may seem that we have a lot more, but if we compared that across rural areas and different states, it would probably still be pretty low as compared to other psychiatric disorders. First degree relatives who are biologic relatives, key is biologic, of persons with schizophrenia have an 8 to 10%, or 8 to 10 times greater risk for developing it if you compare them to the general population. However, most cases are sporadic. So there may not be somebody, their mom, their dad may not have schizophrenia. And it tends to be that people with schizophrenia end up having less children in general. And that may be because of the social isolation. It might be because of the disorganized thoughts that they're not forming relationships that end up turning sexual and resulting in children. A big thing, especially depending on what states or areas you're living in, is whether these people are biologic relatives. There's lots of people who have multi-generational homes. A lot of people that will refer to loved ones as relatives, but they're not actually biologically related. So making sure that you're clarifying, is it a step parent, a half sister? Who is this person in relation to the patient that I'm looking at? So they will differentiate schizophrenia by early onset, meaning before the age of 18, as opposed to childhood onset before the age of 13. And again, very, very rare to have childhood onset. Some things that have been seen is, again, daily cannabis use. Especially high potency marijuana increases the odds of having a psychotic disorder. So this is a lot of the kids who come in and say that they use the dab pens. That's typically the oil, which is a higher potency as opposed to smoking or edibles. So you can ask them, like, how do you use marijuana? And have you heard that it's any higher concentration, or is it a synthetic type? Because that'll increase their odds as well. So the positive symptoms of schizophrenia are the things that are very, very noticeable to people, as opposed to the negative symptoms. That is the things that used to be normal and now are not there. So you can think of positive as this thing's happening in addition to what we would consider normal thought or normal behavior, as opposed to negative, they're lacking these things. So hallucinations, delusions, disorganized thoughts are considered positive, and everything else is considered negative. So not really having much emotion in their expressions, inability to speak. Some people will have lack of motivation and lack of ability to complete even small things like daily hygiene. It could be somebody who stopped making meals, stopped washing clothes, stopped putting clothes on. And then anhedonia, so loss of interest or withdrawal from pleasurable activities. Why people think it began, there's genetic effects, it tends to be additive, and then there's environmental influences for vulnerable individuals. Some people have a dopamine hypothesis that it's too much dopamine, and specifically an increase in the D2 dopamine receptors in a particular portion of the brain called the caudate nucleus. And there's also dopamine concentration increased in the amygdala, and then a decreased density of dopamine transporters. So basically, it's stuck there, you can think of it that way, and it's not going to other places that it may be needed. So having an excess in certain areas leads to those positive symptoms of hallucinations and delusions, and the inability for dopamine to get to other portions of the brain is leading to those negative symptoms of anhedonia, avolition. And then there's also thoughts that serotonin can play a cause, again, in excess of positive and negative symptoms. It is thought to be additive in terms of genes, aka if you went to a geneticist, they would not find one gene that they called the schizophrenia gene. It's multiple genetic changes that seem to add together and potentially prime someone. And then oftentimes having environment on top of that primed genetic environment can lead to development of schizophrenia. So to get the diagnosis, you have to have two of the following. One of those symptoms has to be the top three, and these have to last for over a month. So they have to have either delusions, hallucinations, or disorganized speech. And then they have to have continuous symptoms that last longer than 6 months. If it's not lasting that long, then you might give them a temporary diagnosis, basically. Or you may just leave it as something unspecified and say, not a long enough time period and continue to assess them. The signs and symptoms that families might notice, they could be very quiet, passive, could have few friends. So that's the things that maybe are before their full diagnosis is kicked in. And then prodromal, so these are the first inklings. A lot of families cannot remember these until people are hospitalized, and then they look back and they say, oh, now that I'm looking at it, these might have been signs, but I didn't pick up on them. So someone can be a spectrum of obsessively groomed to disheveled, screaming, agitated. The most common hallucinations that someone with schizophrenia tends to experience are auditory. And the voices tend to be threatening or obscene or accusatory. They don't feel like nice voices. People do not like having them. The other types of hallucinations that are unusual are tactile, so feeling, olfactory, smelling, or gustatory, tasting. Those types usually point us in the direction of, hey, we need more of a medical workup because there might be something else going on. And then disorders of thought, it can be the thought content. So the actual items that one is thinking about, they could have delusions. They could stop having a clear sense of where their body and mind end, and then inanimate objects begin. They can have ideas of reference, like reading something and feeling that they're getting special messages from a book or from TV that are just intended for them. And then they could even feel fused with another person or that an outside entity controls them, as opposed to their thought form. So the way that thoughts connect to one another, it tends to be loose. They can have derailment. It could also be incoherent, or they could show neologisms as they're creating new words that don't exist. Echolalia, they're just saying back whatever somebody else is saying or saying back the sound that an item makes. And then thought process is the way that the ideas in language are formulated. So they could have thought blocking where they're talking, saying a sentence or a thought, and suddenly it just stops in the middle and it's like they lost their place. They could have poverty of thought, aka nothing is coming out when you're asking them questions. They're just sitting there still as if they don't have any thoughts. Perseveration, they continually go back to the same conversation or portion of conversation despite bringing up other items. It's like they're fixated or hinged on that. And then sometimes they can believe that they have thought control, so they're controlling someone else's thoughts or vice versa, or that their thoughts are being broadcast for other people to hear. The progression that typically happens is you might have those premorbid symptoms before any disorder has begun. And then usually these first inklings, the first signs are social isolation, academic difficulties. They might get preoccupied with really strange things. This can happen a huge amount of time, like days to weeks, or it could be occurring very, very slowly over the course of years. So it is very hard for parents to pick up on these things. And when they look back, they might be second guessing, should they have noticed? Could they have picked up on it sooner? And it's really hard to say. The acute phase is when there's a lot of positive symptoms. So a lot of things happening in excess, disorganization, hallucinations, delusions. It can take a long time to recover from that. And there can even be incomplete resolution in younger people. And then they may have a recovery phase where it's now going into the negative symptoms where they have flat affect, they're really not motivated to do anything, they're not getting enjoyment or pleasure, and then the residual phase. So suicide is a major cause of death among those with schizophrenia. It's a high percentage of 5 to 15% of people with schizophrenia die by suicide. Some helpful screening questions that you can ask. Have you seen visions? Other things that people did not see? You feel like people are trying to follow you or hurt you? And then while watching videos or listening to music, have you ever felt that it was referring or sending just you a message? And then when you're awake, do you ever hear a voice different from your thoughts that other people cannot hear? When you're awake, do you ever see people or see things that other people cannot see? And again, I will tend to phrase these as I'm going to ask you some questions. It's not unusual for these things to happen. And sometimes it happens at different points in people's lives. Sometimes it happens when their mood feels pretty okay. Sometimes it happens when they're depressed. Sometimes it happens when they're sick in the hospital and it's an unfamiliar environment. Do you ever feel like your mind plays tricks? And then I'll wait. And if they have an answer, great. If not, I'll say, do you ever feel like you can't tell what's real and what's not? And then they might expand upon it. And then I'll say, do you ever feel like your eyes are tricking you? Like you're seeing things and you're not sure other people can see that. Okay, can you tell me more? Or do you ever feel like your ears are tricking you? You're hearing things and you're not sure other people can hear those. Okay, tell me more. Because usually you can whittle it down. So if someone says, you know what, I heard somebody say my name this one time. Okay. And were you able to kind of look around and know that someone wasn't there and talk yourself out of it? Yeah. Or I was really worried that I was going to be late and I thought I heard my mom call my name. I don't really worry about those because that happens to everybody. But if they continually hear someone whispering their name, it's not a voice that's familiar to them. It sounds like it's outside their head. It's not their own thought. It's interfering. It's upsetting to them. Then that's where I get, I guess, more concerned and I'm asking more questions that might be indicative of schizophrenia. So here's a case, 13-year-old male. He is alleging that mom is trying to rape him and making sexual advances. And he's saying this even while I'm in the room and mom is in the room. He then jumps off the bed and is shouting at her, saying these things when she's obviously just standing there. He's had little need for sleep, so he might have gotten a total of 6 hours, but it's broken and he feels like he doesn't really need it. He describes this really robust knowledge of time travel devices. He's got a lot of stuff written up on the walls of the room that he's in because there's chalkboards on the walls where kids can draw. And it goes through all these different things, some of which I don't think exist, like the words are not true words. He describes hearing special religious messages. He has increased confidence. He keeps saying, if everybody was as smart as me, they would understand this. And then he's only having homicidal ideations towards the devil. He denies any increase in sexual interests. And he's focused on getting ready for a track meet in Texas. Mom tells us he doesn't actually run track, nor is there a track meet. He's having flight of ideas, so like a ton of different ideas popping up. His speech is very pressured, where it's like he can't get his thoughts out fast enough. He can't say things quick enough, and it's very hard to interrupt him. So in our discussion, he said, I'm better. And he talks still a lot about time travel. Throughout staying here, he's saying, I'm not as worried. She might still be trying to rape me, but she can come if someone's watching. he still thinks that he has kind of an increased ability to hear things. So he describes being able to hear people in the waiting room, people talking about him, but he said, oh, it's really good. They're saying really good things about me. And then he also thinks that he can see better. He can see into other dimensions. He can see what's going to happen in the future. Still talking about religious delusions. He feels that his thoughts are moving quickly. And again, he said, I just need smart people who think like me, who can think as fast. No longer having any homicidal ideations other than towards Lucifer. He's very thirsty, and he's aware that we're going to increase his lithium dosage and check to make sure that he's not drinking too much water. Again, he's not quite sure about medicine because he thinks his body will overpower the medicine. And he thinks that he's feeling just fine and that he doesn't really know that he'll need the medicine. So getting outside information is helpful. So it turns out he's been making threats to mom that he's going to leave the house. He needs to go to school. Mom has been preventing him from going to school because of this increased mood and these delusions. He's been very irritable. He's threatened to kill mom. He has had one past behavioral health stay, and mom lets us know that she thinks biologic dad had bipolar disorder. He's previously been on a high dose antipsychotic, but not shown any improvement. And then he was in our emergency room, and I had asked for a crisis responder to come and evaluate him for detainment because he was unable to give consent and he was showing grave disability. So he was actually detained. He initially had a diagnosis of unspecified schizophrenia, but after seeing him and getting collateral and talking with him, observing him, it was now pretty evident that his correct diagnosis was bipolar disorder. He was currently manic, it was severe, he was having psychotic features, and he was able to be stabilized by starting lithium, which is a mood stabilizer, and then switching the antipsychotic medication. And in certain instances like this, it may be necessary to involuntarily treat people if they're not able or in a state of mind that they can knowingly consent, or in his case, that he was so manic and delusional that he didn't think the medication would be effective for his body. So with bipolar disorder, the lifetime prevalence for bipolar 1, which is the thing that people think of most, pretty low, 0 to 2.4%. And then bipolar 2 is 0.3 to 4.8%. There's high heritability. Again, there's no specific gene. You wouldn't be able to go and get a genetic test that said you have the bipolar gene. But again, it's probably by genes interacting with people's environments that lead to the disorder. This is different. So when you think of psychotic disorders, these are patients that tend to engage easily or they're very verbal, as opposed to someone with schizophrenia who is more isolated and it tends to be hard to get them to come and talk with you. The onset is puberty into early adulthood. With bipolar 1, you have true episodes of mania, as opposed to bipolar 2, where you have these kind of less symptomatic episodes of hypomania that doesn't cause as much impairment. And then they have to have had a major depressive episode in addition to get the diagnosis of bipolar 2. So mania is a distinct period. That's key. It needs to be a discrete period of time. It cannot be how they are most days forever and always. It can't be how they were for one day. It needs to be discrete period for at least a week, or it was so bad that they needed to be hospitalized before it hit the week mark, of abnormally, persistently elevated or expansive or irritable mood. And then hypomania, it's basically not as functionally impairing, not severe enough, and then a lesser amount of days. And people might have mood congruent, aka mood matching psychotic symptoms. So they're having psychotic symptoms that match their mood. So in his case, he was having visions that he could see people, he could hear people, and he was saying, oh, but it's great stuff. And he was happy and excited. So that would be mood congruent, as opposed to mood incongruent, where it's paranoid. They might be having hallucinations that are the opposite. So they might be in a great mood, but they're thinking that someone's out to get them, or they're having auditory hallucinations saying really negative things about themselves, that would be mood incongruent, aka the psychosis doesn't match what mood they're feeling. The diagnostic criteria for bipolar 1, again, it needs to be a distinct period, abnormally or persistently elevated, expansive, irritable mood, and persistently increased goal-directed activity or energy that lasts most of the day, nearly every day for at least a week. So you basically need more of the symptoms if this person is only irritable. If they're expansive, elated, you don't need quite as many symptoms to meet the diagnosis. With distractibility, it can be either reported or what people have noticed, like outside collateral. The indiscretion, high potential for painful consequences that are abnormal. So this needs to be different. This cannot be a teenager who is always sneaking out, and then during this period, they're also sneaking out. That's no different than what is their norm. Grandiosity, it could be the kids who think, suddenly they're running multiple businesses, they're inventing things, or it could just be much more self-esteem. So in this kid's case, it was, I'm better than everyone. I have a higher intelligence. People need to get as smart as me. I have extra abilities to see and hear. Flight of ideas, it could be a subjective experience that their thoughts are racing. So I tend to ask people, when you're feeling this way, are your thoughts moving slow, medium, or fast? The vast majority will say so fast. And sometimes I've described it as, imagine trying to leave a parking lot and every car's trying to leave at once and it's like they're getting all jammed up. Is that how it's feeling with your thoughts? The activity tends to be increased. They could have agitation. Sleep tends to be decreased, or it just feels like they don't need any sleep. And then they tend to be much more talkative. How it progresses, the actual mania has a pretty quick onset, like it can feel as if it comes out of nowhere. And left untreated, it could last for several months. Delusions, hallucinations are present like a third of the time, and the psychosis tends to be mood congruent. It tends to match what mood they're feeling. And then if people are having depressive episodes with their bipolar disorder, those tend to be very long. If you average them, it could last up to a year. So a lot of people who have bipolar disorder would much rather be manic than they would be depressed, because they know how terrible it has felt and how long it's lasted. It is vitally important to get caregivers to provide symptoms, collateral, timelines. You have to differentiate, is this like a discrete chunk in time? I will often draw it out, use my hands to show them, is it one time period where all of these things are happening at the same time? Or are they consistently irritable? They're always making risky choices. They're always using substances. And then they happen to have these things happen for like a period of a day. That's different. And then it needs to be pervasive. It can't shift. It cannot only happen at home or it's not bipolar disorder. It can't only happen at school or it's not bipolar disorder. Some helpful screening questions that I will ask. Has there ever been a period of multiple days in a row where you were the opposite of depressed? Like you had super high energy, you thought you could do anything? Can you tell me more? I have found that when I ask symptoms for bipolar disorder, it's one of the very, very, very few times where I will lump symptoms together and ask a compound question. Because otherwise, people will say yes to, have you ever had a time period where you were much more energetic? Well, yeah. Or have you ever had days in a row where you didn't need much sleep? Yeah. So I'll always ask them to tell me, what was that time period like? How long did it last? What was happening? What symptoms did you feel all at the same time during those, few days or a week? And then has there ever been a time for many days straight your mood was super happy or much more self-confident, just had a ton more energy? And then did you feel that way most of the day, all of the day? Did anyone else notice? Did it get you into any trouble? And then there's also a mood disorder questionnaire that's available for free. You can Google mood disorder questionnaire and it'll come up, or you can put MDQ, mood disorder questionnaire for bipolar disorder. And it's just like an additional thing that can kind of bolster your suspicion. And it's also helpful just to clarify some of the questions, because it can be confusing to ask the symptom questions for bipolar. And then confusion at all, if you're wondering, is it truly this? You need to look at, is this developmentally appropriate? So you could have like silly disinhibition of kids with ADHD, which is different than consistent high energy where they don't feel the need for sleep. You could have impulsivity from bipolar as opposed to pleasure seeking where they're really going to get into dangerous situations. And then there can be some comorbidities. So you really need to make sure what is happening right now, what is the biggest issue at this time. There are some other psychotic disorders you will not see as often. However, you might have hallucinations that occur because of trauma. With autism spectrum, people can describe hallucinations, but they tend to have linear thoughts. Personality disorders, especially borderline personality disorder, you can see it. And then differential diagnoses could be medical conditions, other psychiatric disorders. You want to make certain, is there anything else going on that explains why they suddenly have a mood change, trouble sleeping, hallucinations? Again, with trauma, you're looking for an absence of disorganized thoughts and behaviors to differentiate it between bipolar disorder or schizophrenia. Autism spectrum, the hallucinations tend to be pretty transitory. They have other things that are the predominant issues like abnormal communication, social relatedness. Again, personality disorders, you're not going to have these diagnoses in kids because it doesn't have long enough for someone to have a stable pattern of personality for us to really call it that. But with personality disorders, it tends to feel good. They don't necessarily want to stop doing whatever that thing is that's functionally impairing to others in terms of their personality. And then here is, let's see, here's a case that was questionably something else. So polysubstance use, no prior manic episodes, but dad had bipolar or schizophrenia along with substance use. This kid was having auditory hallucinations. They've urged him to harm other people. He's having thought blocking. He's having capgras delusions, which is believing that his brother was replaced by an imposter, and a lot of paranoia. And then in getting information, he was using a synthetic, like psychedelic drug, along with marijuana, prescription pills, uses a lot of nicotine. And so in that case, when he got sober, this was not the case. So knowing that the drug was what first caused the symptoms made it a different diagnosis. And then sometimes it's hard to tell, like the chicken or the egg. People with schizophrenia and bipolar disorder tend to use substances, and it's hard to know whether the impulsivity or the depression from bipolar leads to substance use or the other way around. But they often have the same treatment response to antipsychotics, so it tends to be the treatment anyhow. And then here is a case of a medical issue that was actually causing the manic-like symptoms. So this is a kid who didn't believe he needed any treatment. He was talking about buying me, as his physician, a new wedding ring, playing for the Seahawks. He was suddenly taking his shirt off during the interview so that he could show me his stretches and moves. And then when the workup continued, he had very abnormal blood pressures. And when they began doing scans, it turned out that this was likely an adrenal tumor that was secreting and causing these symptoms. So sometimes there's also unspecified when you don't have any particular diagnosis, but you know something is not right. And then most of the treatments depend on the diagnosis. So it could be mood stabilizers or antipsychotics if it's bipolar or schizoaffective or schizophrenia. But otherwise, it's appropriate treatments for those disorders. And we just acknowledge that hallucinations are happening and try to help people through them. And then I listed some terms that you might run across just as kind of a glossary. And then those are the references. There we go. So I got through it all. Ask me any questions before we get kicked out of this meeting.
We have a couple minutes if Dr. Rensko does as well. So if you do have questions, feel free to put them in the chat, or I can help unmute you if you raise your hand. Otherwise, the evaluation for today's training is in the chat box. I will send out another email with the link to the Teams video recording. If you work for Multicare, you'll have access to it. If you do not work for Multicare, you can access the recording on the Kids Mental Health Pierce County website, and we'll send those links out as soon as they're available. There are no CEUs for today's training or yesterday's training, so just another reminder about that. But we appreciate your time and willingness to participate with this. And Dr. Rensko, thank you so much for sharing your expertise with all of us. All right, I'll go ahead and end the meeting. Thank you all.